Hi, and welcome to the final course review for the Death and Dying course. What I'm going to try and do here is to go over the most significant concepts that we covered in the course. There will not be everything, and I may even miss something that you think is really significant, but these, I hope, will be the most significant pieces of what we did together this semester. First of all, we asked the question, what is your personal experience with death? There was a very good reason why we did this. One, I wanted to find out what you already knew, but secondly, I wanted us to have a chance to talk about death and about our experience with death as a way of helping each other to understand what normal is. All of us tend to shy away from death and from conversations about death and experiences with death because it is a big, scary thing that frightens us. So if we can talk about it, we can kind of pull it out from under the bed and the dark places where it lives, and we can begin to examine it for what it really is. Also, it helps us a lot when we talk about our experiences with something to realize that other people probably have the same kind of experience, and that, in fact, our experience is not so strange, weird, abnormal, and scary as we once thought. The other aspect of this is that our experiences about death do, in fact, color how we relate to people who are dying or who are grieving. And we need to know about this, because if we don't know about it, then we'll make certain assumptions and presuppositions out of our prejudices and our biases and our assumptions, rather than out of our clear-cut understanding of reality and our desire to be compassionate caregivers. So we talked quite a lot about our experience with death and some of the many ways in which each of us have had death be a part of our lives and how we've handled it. And I hope that that was helpful in helping you to understand that this is a normal human experience, even though it always appears to be abnormal, because in most cases it is unique to us in the way it shows up. One of the significant concepts in the course was an analysis of just how it is that human beings die. We read Sherwin Nuland's book entitled How We Die. Dr. Nuland records all of the many ways in which human beings meet their end and describes in some graphic detail just exactly what happens. What it comes down to, of course, is that cells run out of oxygen, and especially brain cells do that rather quickly. But there are a million ways in which that outcome is reached. Cancer, heart attack, stroke, respiratory distress, all kinds of possibilities. But the thing that we wanted to get out of this was an understanding of not only what happens pathologically when somebody, or physiologically when a person dies, but also just what that experience looks like to those who are standing by and watching. My theory here is that if we examine something and we give it names and we look at it in cold, hard light of reality, then it tends to lose some of its fearfulness for us. Now, it may have been that you experienced somewhat the opposite, in the sense in which Dr. Nuland's graphic explanations might have freaked you out even more about the subject of death, but that's probably a transition state, and probably it will ultimately help you to understand just exactly what happens when a person dies and know better how to deal with it. Another aspect of how we die is the situation in which we die, not just the physiology and the pathology. Most people want to die at home, but most people don't die at home. Most people die in the hospital, many die in a nursing home, some die in hospice. But the reality is that for most Americans, Death will take place after a hospitalization. Even if collapse comes at home or on the street, the person will usually be taken by ambulance to the emergency department, and if successfully stabilized, will then be transferred to a hospital room. And death, if it comes, will probably come in either the ICU or in a patient room. But in most cases, people will not die in their own bed. They will not die in their own home. They will not die surrounded by family and friends. They will be in a clinical environment. And this has huge implications for what kind of ministry can be done and what kinds of needs dying people bring to the hospital with them. In addition to that, oftentimes people will die without an advance directive of some kind, so that we will not really know what it is that they want their dying to be like. They will never have told somebody what they want their dying to be like. They will never have written it down. It will never have found its way into their chart, or if it did, the chart will be in some other hospital someplace. So the problem of how we die has many different facets to it, not just physical facets, but psychological and social and emotional, cultural and spiritual facets as well. Dying has changed quite a lot in America over the years. If we go back even before America to the earliest kinds of civilizations, we realize that in many cases, people died when they could no longer keep up with the tribe as they moved, and they would be picked off by predators. People simply couldn't continue to provide for those who couldn't take care of themselves. Sometimes they would be left behind. Sometimes the rigors of the daily life would kill them. It was only when human beings began to live in settled agricultural and then industrial communities that the possibility of long-term health care became a reality. And on the American scene, many people on the frontier had to be their own doctor, their own nurse, and when somebody got sick, the most capable person in the family or in the village would care for them. Even in the days when physicians came to be more common, they were oftentimes not very well trained and not terribly skilled. They had very little to offer. In the early days, of course, there was no anesthesia. There was no effective analgesia. There was no sterile technique. There were no surgical procedures. And so for the most part, if you got sick, you just toughed it out until nature took its course. And that would often happen in your own bed, in your own bedroom, in your own home. The virtue of that was that you were usually surrounded by your family and your friends. The downside of that was that it could often be a painful, protracted process with very little possibility of any kind of relief. Over the years, medicine has gotten more and more scientificated, and as a result, a good result, we have things like medications that will relieve pain, anesthesia and surgical techniques that will remove tumors and solve problems. The downside of this is that we have the ability now, as a result of the scientification of medicine, to prolong the dying process almost indefinitely. We have machines that can take over the functions of various organs like kidneys and lungs and heart, and it's possible to maintain a person in this artificially maintained state for quite a long period of time, sometimes even years. This raises all kinds of ethical questions then about how we should continue or discontinue the treatment of those who are seriously or terminally ill, especially if they are not able to make the decision for themselves. 100 years ago or so, people generally would die in their own homes. Now they will generally die in a hospital or a nursing home or in hospice. This has changed the way in which families can interact with dying patients and the kind of social and cultural and spiritual support people have as they die. Also, because people are a lot less familiar with death and dying than they used to be. For example, we don't even kill our own animals for food anymore. Many people don't know what to do when somebody is dying. It is such an unusual experience to confront death in modern America that people tend to be more freaked out by it than they used to be, and are at a real loss to know what to do for people who are dying. In earlier days, death was so much a part of day-to-day life that people had a better understanding of how to deal with it. Not so much today. Also, we have changed the whole culture surrounding death and what the expectations are in America. In other civilizations, in other societies, in other ages, the grieving was quite different than it is now. People, generally speaking, are expected to take care of their sick and to spend whatever money is necessary to try to get them well, and if that doesn't work, then they die, and the funeral home kind of takes it from there. This, too, is quite different than the way it used to be, when people would generally take a body into their own homes, wash it and dress it, display it perhaps in the front room for the family and friends to come and visit, and then take the body to the church for a service, and then to the church cemetery for burial. That kind of thing doesn't happen very much in America anymore. Dying has changed. Dying has become more of an industry than something that families used to do for their loved ones. In earlier ages, people didn't have the luxury of death denial. Death came in your own home. Death came on the street, and people were routinely, even children, routinely exposed to death and all of its realities. But again, since that doesn't happen very much in America, since dying usually takes place safely tucked away in a hospital somewhere beneath white sheets, we don't have to face it like we had to, so we can do a kind of death denial. We don't have to see the person while they die because we have paid physicians and nurses who will care for the person right up until the very last. We don't have to touch the person because we have undertakers who will wash the body and prepare it for the funeral. We don't have to dress the dead person because people are paid to do that. When we do see the person, they are usually laid in a very nice casket. Their hair has been washed and combed. Their face has makeup on it. They're dressed in their best, and there's a nice pink floodlight restoring a rosy glow to their cheeks, and they are surrounded by flowers in the funeral home, and the smells and the sights and the touch of death has been masked by all of these things so that we can, in fact, do a kind of death denial. This is probably not healthy for us, but it is usually the way we do it in America. The bottom line is that we grow up not really knowing how to deal with death, not really sure how we feel about it, not really sure what to do when we do have to encounter it. For example, when we go into a helping profession like nursing or medicine. Death denial in America has become so pervasive that people routinely talk about if I die rather than when I die. In earlier societies, people kind of specialized in preparing themselves to die. There were even books written about the art of dying. No more. Now we live as though we will never die. And if we do die, note the irony there, somebody else has to deal with it. Somebody who's paid to deal with it. A doctor, a nurse, an undertaker, a mortician. I'll let you decide for yourself just how healthy or unhealthy this may be. The end result of all of this is that many of us don't know very much about how to take care of dying, grieving people. We would prefer to tuck them away where we don't have to deal with them, where somebody can do their grieving either for their own lost life or for the life of someone that they love, away from public sight, out of mind, so that they can muddle through the best way they can, and the rest of us don't have to think about it because we don't want to think about it, because it's too painful to think about it. In the class, we looked at the work of Dr. Elizabeth Kubler-Ross in the 70s. We give Dr. Ross a lot of credit because she was one of the first clinicians to look seriously at what we could learn from people who were dying. As I said previously, at this time, the general tendency was to take people who were dying or grieving and tuck them away somewhere in a private room down at the end of the hall with the door closed, so that we didn't really have to experience what they were experiencing. Dr. Kubler-Ross was fascinated by what people could teach her who were themselves dealing with death. And so she began listening to the stories of those who were dying and recording their experiences. She also began interviewing them for other physicians so that they too could learn from the stories of the dying. Out of those experiences, Dr. Kubler-Ross wrote her book on death and dying, in which she laid out the stages of grief. Now, this has been misunderstood and misinterpreted. She may have initially thought that people move through these stages, but she also recognized and said in her book that people move back and forth between the stages as well. So this is not a nice linear progression, but the stages, you remember, are denial and anger and bargaining and depression and ultimately a kind of acceptance. Dr. Ross believed that dying people and grieving people experience all of these stages to some degree, more or less, in some order. Most people do start with denial, and it is usually the go-to place for people who are overwhelmed by what's happening to them or to their loved one. Denial means that the person is simply not able at the moment to deal with the reality of death, and so they are, in a sense, taking refuge in some inner place that just doesn't let it in. Anger is another very important stage that most people who are dying and or grieving go through. And this anger, remember, is simply anger. It is kind of a diffuse and unfocused anger. Oftentimes, healthcare workers become the object of this anger, but that doesn't mean that they are angry with you. It simply means that they are angry, and you happen to be a convenient target. A number of people do bargaining to a greater or lesser degree. Bargaining is the idea that if I do this, then perhaps God or nature or somebody will do that, and I can get off the hook here. So, God, if I dedicate my life to you as a missionary, perhaps you'll heal me from my cancer. Or, God, if I give all my money to the church, perhaps you will heal my 10-year-old daughter from leukemia. Or whatever it might be. Some people go from one bargain to the next, but most people recognize fairly soon that this is not a very adequate way of dealing with their grief and their dying. Depression is a common experience for people who are dying or who are grieving, so common as to be, in a sense, the defining expression of grief. Depression results in a number of inabilities, the inability to cope, the inability to get out of bed, the inability to eat, the inability to relate to other people, the inability to accomplish daily work tasks or to take a shower or to do necessary stuff. And this depression can be so debilitating that people really do themselves want to die. And again, it isn't terribly helpful to try to talk people out of it, but simply to be with them in their depression, knowing that eventually they will work through it, eventually they'll get past it, eventually they'll get better, and eventually people will get to a place that Kubler-Ross describes as acceptance. Now, this doesn't mean that people are happy about dying. It just means that they recognize that it's going to happen, it's inevitable, they can deal with it, they'll be okay. Kubler-Ross's book on death and dying has been reinterpreted in a number of different ways so that people not only talk about the stages of grief, but they talk about the phases of grief, the phases of dying, and those sorts of things. But again, Kubler-Ross was the groundbreaker here, and we honor her for her work. We talked about normal or simple grief in the course, and I hope that I described it to you in such a way that you said to yourself, wow, if normal grief is so debilitating, then what would abnormal grief look like? Normal grief is debilitating. People think that they're not going to get through it. It is so bad that people think that they will quite literally die from their grief. Even so, this is a normal response to the very abnormal experience of losing somebody very close to you. We probably were not made to experience grief, and as a result, it just doesn't seem to fit in our psyche anywhere. We have a hard time accepting it, and as a result, our reaction to it is pretty devastating, pretty profound. We call that normal grief. It has a number of symptoms, and we talked about them in class. You can go back and review your notes. There are a number of physiological and physical symptoms. There are emotional symptoms. There are spiritual symptoms. There are social symptoms. People tend to withdraw. People get depressed. People tend to question God. People tend to doubt. People tend to want to stop living themselves. Sometimes they can't eat. Sometimes they can't sleep. Sometimes they hear voices, particularly of the one who has died. They think they're going crazy, and that's all normal. The main difference between normal grief and abnormal grief is that normal grief eventually starts to fade away. Abnormal grief could be defined as normal grief that just goes on and on and on. Abnormal grief is the kind of grief that leads a person to some kind of self-destructive behaviors like addictions, drinking, drugs, something like that, that the person tries to do in order to medicate the pain, and that in itself tends to create more pain. And so it becomes a vicious feedback cycle in which the grief never really goes away. Oftentimes, abnormal grief is worse if the death was very messy, a suicide perhaps, or a murder. Sometimes the abnormal grief is even worse if the person has a great feeling of guilt, like maybe a broken relationship with the deceased, so that they feel terribly guilty and wish that they could do it over again somehow. There are a number of reasons why normal grief becomes abnormal grief. But the question of most urgency is, what can you do about it? And the answer is that if you really think that this is abnormal grief, then it's time for some professional help. This would be a referral to a psychiatrist or a psychologist or some kind of therapist who could work with the person and who understands enough about the grieving process to be able to help them to work through the complications of their grief. Death, grief, and bereavement are all part of the same process. Obviously, death kicks it off. This could be an impending death, in which case the grief is anticipatory grief, where the person around the person who is dying anticipate that person's dying and begin grieving. Also, the person who is dying does his or her own anticipatory grieving. And this also can be quite profound, needs to be handled as a category of grief. Grief is what we feel when we lose something that's very close to us, very important to us, something in which we have highly invested. It doesn't necessarily have to be the loss of a life. It can be the loss of a friend, it can be the loss of a job, it can be the loss of a home, the loss of a pet, it can even be the loss of a limb, the loss of a toe. People grieve about anything that they are very attached to that they have lost. The stages of grief are fairly well known, and the process of dealing with grief is called bereavement. Bereavement goes on for some time before the death and after the death, and Bereavement is something that requires the active participation of a number of people with the person who is grieving in order to help that person work it through by listening to stories, by looking at photo albums, by reminiscing and rehearsing memories, and by simply spending some time listening to that person do their grief work during their bereavement process. Death and dying is obviously a pretty big part of healthcare. The fact of the matter is that every single patient you take care of will eventually die. Maybe you will die before they do, but every single patient you care for will eventually die because the mortality rate for the human rate is and always has been 100%. So in a very real sense, all of the health care that we do is a kind of palliative care. Ultimately, it comes down to taking care of people the best way we can while they're in the process of dying. So we remember in healthcare that our job is to cure sometimes, to relieve symptoms often, but to comfort always. We can always do that. Healthcare workers are, like all human beings, afraid of death. We tend to identify with our patients who are dying, and that threatens our own sense of our personal human existence. We tend to run away from that. We don't like it. It feels uncomfortable. And we sometimes will try to escape those uncomfortable feelings by ignoring people who are dying or who might die. This has become such a recognized phenomenon that it has been studied a number of times and has demonstrated pretty conclusively that patients who are dying tend to feel rejected, they tend to feel abandoned, and in fact they have good reason to, because healthcare professionals tend to isolate them and to spend as little time with them as possible at a time when they need them the most. Another aspect of this is that people who go into healthcare really want to help, and when people are dying, it feels like we're not helping them, and so we feel like losers, we feel like failures, and nobody likes to be reminded of their failures. Sometimes this is a function of having a very wrong attitude about healthcare. If we think that we can have some kind of messiah complex in which we will save all of our patients from healthcare, we will be like that doctor in the picture who stands between the patient and death and says to death, "No, you shall not pass," then we probably have a messianic complex about our healthcare that is going to lead us to frustration and a sense of failure and probably ultimately to burnout. We need to be realistic about what we can and cannot do for our patients. The thing that makes it so difficult to care for dying patients is this thing called identification. We recognize that we're human, just like they are, that we have lives just like they do, that we could get the bad news that we are terminally ill just like they did, and then we would have to go through the dying process just like they're going through it. And we tend to identify with them in our common humanity. This identification can get much worse, much more profound, if, for example, they are closer to our age, or if they have similar life stories, or there's something about them that sort of reminds them of ourselves, or maybe even of somebody that we love. And while it's right and proper to have sympathy for those who are dying, identification can push us to the place where we're no longer able to be helpful. Sometimes it's necessary to get somebody else to take care of this patient because we over-identify with the patient and we haven't yet learned how to deal with our own feelings of grief and remorse about death. But hopefully we are mature enough in our healthcare skills so that we can recognize that we are identifying, but we can still offer sympathy and we can hurt with that person and yet still be helpful to that person because we know how we feel about ourselves and about death and about our own deaths. So if we can, in a sense, retain sympathy and empathy, but not be so freaked out by identifying with our dying patients that we can't be objective enough to care for them, then we've got the best of both worlds. Compassion fatigue is a fairly common phenomenon among healthcare workers. You start out all bright-eyed and bushy-tailed, and you want to help people, and you see yourself as an extremely compassionate person, and then you have a patient die, and it tears you up inside, and then it happens again, and it happens again, and again, and again, and again, and you find yourself so overwhelmed with a sense of grief and a sense of loss and a sense of pain that you find yourself thinking, I can't do this anymore. And at some point you wake up in the morning dreading to go to work, and when somebody looks really sick, you try to avoid getting that patient because you just don't want to deal with it anymore, and you are experiencing compassion fatigue. It's a fairly common phenomenon. In fact, some years ago we did psychological testing on healthcare professionals and discovered that the longer somebody was in healthcare, the lower they scored in sympathy and empathy, and the more they struggled with compassion fatigue and burnout. These are real things. We have to take care of our spiritual selves, our inner selves. We have to take care to be sure that we ourselves are maintaining our spirituality in a way that keeps us strong and enables us to be the kind of people who can give to other people the kind of compassion and the kind of care that they need as they deal with death and they deal with dying. However, if we can't do that, then we need to kind of step aside for a little while and refill our reservoirs and get ourselves straightened out, because we really cannot be helpful to our patients when we are experiencing this kind of burnout. I've heard story after story after story from physicians and nurses who say, I just can't take it anymore. It just isn't fun anymore. I feel like I'm dying. And then they have some kind of a spiritual renewal, and they say, okay, I can do it. I'm ready to go again. This is okay. I understand now why I went into this in the first place. I love it again. It is a kind of conversion experience that we have to have that keeps us constantly renewed so that we don't burn out. One of the things that we do to try to protect ourselves from the pain of dealing with people who are seriously ill or dying or who have died, those who are grieving the death of someone that they love, is to objectify people, to sort of push them away a little bit and to relate to them more as objects than as persons. We tend to relate to them as patients rather than people. We relate to them as the brain tumor in 223 or the cancer in 414, rather than as Mrs. Smith who has cancer. When we objectify people, then we can treat them as objects rather than as persons, and this takes some of the sting out of dealing with their potential loss. We talked in class about I-it relationships, where I have a relationship with an objectified you. So I make you into a patient, or a student, or a store clerk, or a mechanic, or the guy who cuts my grass, rather than I-thou relationships, where I relate to you as a person, as a human being, as a child of God, as a husband, as a wife, as a father, as a son, as a child, as a sister, as a brother, as a human being with struggles like mine, and who feels pain like I do. So oftentimes, objectification is a technique that we use when identification has caused us to hurt too much. And once again, the cure for this is spiritual renewal. We have to have our spiritual well springs constantly renewed by our own relationship with God and our own sense of being okay with God, of being loved by God, of being filled with the presence of God, so that we can relate to people who are in need as human beings and not as objects. We can do those I-thou relationships, and we can minister to people out of a rich well of love and compassion and sympathy that is constantly being renewed inside of us by our relationship with God, or, if you must, a higher power of some kind. This kind of spiritual wellspring is what enables us to be compassionate caregivers. We talk quite a lot about the ministry of presence, and I said to you that in college you learn a lot of things you need to know, and you learn how to do a lot of things you need to do. But in some classes we concentrate specifically on becoming the person that you need to become in order to be the kind of healthcare giver that you want to be. This being, this becoming, this sense of who we are, not what we know and not what we can do, but simply who we are. This is what we bring to the ministry of presence. And the amazing thing is that presence is a very, very good ministry. Ultimately, people don't care so much about what we know or what we can do. Ultimately, they care about the kind of person that we are and the way in which we are towards them. What we bring to them in terms of compassion and kindness and gentleness and goodness and humility is far more healing to them than the things that we know how to do or the things that we know. This is the ministry of presence. And there comes a point, of course, where that's all we can offer people. We don't have any more surgeries that will help them. We don't have any more medications that will help them. There's nothing else we can do for them except simply to be with them as they live out whatever is left of their lives. And the amazing thing is that people find this really healing. They find it really comforting. We tend to think that we need to do something for people who are dying. And sometimes we avoid them because we don't know what to do or we don't know what to say. It's a big mistake because what they need from us really is simply our presence, just to be there. And in that presence to say, I love you, I care about what's happening to you, I'm here for you. I don't know anything else to do except just to be here and accompany you on this journey that you have to make, but I can walk to the gate with you. That's the ministry of presence. And we can exercise it by sitting next to a patient's bedside and saying or doing nothing, just holding their hand, just being silent, just showing them that we care. Sometimes we avoid doing this because it feels so helpless, but it is of tremendous help to the person who needs it and needs nothing else. We talked a fair amount about what dying people need, and lumped into that, of course, is what grieving people need, because oftentimes they are the same person. A person who's dying is grieving his or her own impending death, and the needs of the grieving are very similar to the needs of the dying. But helping people to die, we pulled a lot from Kessler's book on the needs of the dying, and we talked about a number of things that not only do dying people need, but that dying people have a right to. And we talked about paying attention to those things and making sure that our relationships with our dying patients are marked by the recognition of those things that the dying person needs, and that we are never going to do those things that violate the rights of the dying. When people hear the news that they are about to die or that death is going to be nearer than they thought, they react to it in some fairly predictable ways. And Kubler-Ross's stages of dying come into play here. Oftentimes people will respond with a kind of denial that says, no, I don't believe it, there's been a mistake, somebody got my biopsy results mixed up, I'm going to get a second opinion, I'm going to get a third opinion. But eventually they get down to the place where they recognize that they need to start preparing for their death. And this is the place where we can really be of tremendous help for them as we talk to them openly about their impending death. Now, we don't force this down their throats. If they don't want to talk about their coming death, then we don't force them to talk about it. But if they do, then we are eager to discuss it with them. Oftentimes, nobody else will talk to them about it. Sometimes family members are all protecting each other, including the dying person, from the news of their coming death. And so everybody knows it's happening, but nobody will talk to each other about it, and so there's no help for anybody there. So as a healthcare professional, you can have that conversation if the dying person wants to have it, and help them to prepare for their coming death. And questions like as, what do you need to do in the time that you have left? Do you have anybody that you need to say to, I'm sorry? Do you need to say to somebody, thank you for what you've done? Do you need to say to anybody, I forgive you? Is there anybody that you need to say, I love you? Bioc talks about these things that people need to say towards the end, and we can help people to do that. We can facilitate that conversation. We can ask the question, and we can help them to come up with the answers. Also, in preparing for death, people will need to think through what their options are. This is often a place where a palliative care specialist can come in and can help the person recalibrate. Curative care has said, this is what we're going to do to try to cure you, but curative care comes to the place where it says, oops, we're kind of out of options for what we can do to cure you. And this is the place where the palliative care specialist can say, but we still have options. There are lots of things that we can do. Perhaps we can't cure you, but we've got lots of things that we can still do for you. So let's talk about those things that you want or those things that you don't want that we can offer to you. This preparing for death can take place rather quickly, sometimes in a matter of minutes, but sometimes it can take place over a period of months and months as the person gets ready for that final event. One way in which a person needs to prepare for death is through advance directives. Advance directives can take different forms. It can take the form of a living will, in which the person says, this is what I want in this circumstance, this is what I don't want in that circumstance, and that living will is signed and often usually notarized, witnessed, and then is placed into the patient chart or into some place where the patient's family can get hold of it if they need it. Another form of advance directive is the durable power of attorney for health care. And this appoints a person to make healthcare decisions for the patient if and when they're not able to make them for themselves. As long as the patient can do that, then they do that. But if they can't make the decisions themselves, then the person with the durable power of attorney for healthcare is appointed to do it. If a person doesn't designate somebody to have durable power of attorney for healthcare, then the right to make a decision for a patient who can't make the decision for himself goes to the next of kin, usually the spouse, if the person's married. And that may or may not be a good idea. So it is often a much better idea to have somebody designated ahead of time to make those decisions, who knows what you want, and you've had conversations with that person about what you do want and what you don't want, so that that person can then say, I've talked with him, I know what he wants, this is what he would want done. These advanced directives include things like do not resuscitate, if my heart stops, don't restart it. What kind of resuscitation measures do I want? I don't want to be intubated. I don't want to have compressions, but you can give me medication if necessary to try to get things going again. Or if I want comfort care only, all of those things can be spelled out in the advanced directives. Many, many, many people don't have advanced directives. Most people not only just haven't gotten around to it, but they don't really want to get around to it because it's somehow admitting that death is inevitable. Well, guess what? It is inevitable, and to deny it is a crazy kind of thing to do, but we do it, we human beings. We don't have advanced directives, just like we don't make out a will to dispose of our property. We don't make out advanced directives to give directions for health care when we're no longer able to give them ourselves because we are unconscious or too weak. In America, funerals are the traditional way of dealing with death. It used to be that funerals began in the home where the body was presented for friends and neighbors and family members to come and pay their last respects. and then the funeral moved to the church, where the local clergyman, who was known to the family, who had probably baptized the babies and buried the grandparents and the parents, would perform a funeral service that reminded everybody of the hope that we have of an eternal life. And then the burial would usually be the burial of the whole body in a cemetery, where the family would be able to pay their respects for years and even decades to come, because people were going to continue to live in that community until they themselves died. With the changes in America that have taken place, funerals have also changed rather drastically. It isn't at all unusual now for a funeral to be a memorial service, which can take place days, weeks, even months after the death has taken place. Historically, funerals had to take place within a few days after the death, simply because there was no adequate way of maintaining the body much longer than that. Nowadays, cremation is an option that a lot more people use, and the body can be cremated soon after death, and the ashes can be stored until whatever time is convenient for the family to gather from the four corners of the earth in order to have a memorial service. Sometimes people will opt simply for a graveside service, and they won't have a church service. They will simply gather together around the grave for the burial of usually the ashes, in some cases the body. In the same way that the disposition of the remains has changed, so the funeral service itself has changed. Oftentimes it's not held in a church, partly because many people don't have a church of their own. Oftentimes the funeral service is held in what's called a funeral home, or a mortuary, or a funeral parlor. These are businesses that cater to the needs of the grieving, and most of them have a chapel of some kind where a funeral service can be held or a memorial service can be held. This is convenient for the funeral director, sometimes also known as the undertaker or the mortician, because they can take the body from the funeral to their funeral home. They can prepare the body by embalming and all the stuff that they need to do to make the body presentable. They can sell the family a casket. They can put the body in the casket. They can have the casket in their chapel. The service can take place there. They can load it into their own hearse and then take it to the cemetery, and it's sort of like one-stop convenience. And many people opt for that rather than a church funeral. Funerals typically consist of some music and some prayers, and usually some words spoken about the person who has died, kind of memorializing their life and covering the main events in their life. And then some kind of a reference to God, to Jesus, to Scripture, to eternal life, to the traditional understanding of Christianity and what happens to people when they die. Of course, other faiths also have funeral traditions. Jews, Muslims, Buddhists, Hindus all have their own rites and ceremonies for funerals. And if you've never been to a non-Christian funeral service, you might take advantage of an opportunity that might come up to see what it's like. The funeral rites vary widely from religion to religion and from culture to culture. The ways that people grieve vary widely. Some people grieve very privately, very quietly. Other people grieve very loudly and very openly and very publicly. So you see a lot of variation here, but the point of the funeral is that it helps people to gain closure. It helps people to grieve. It helps people to express what they need to express. It helps people to start the grieving process, which will go on for some weeks and months after the funeral, but it gives it a good start. It also is a time for public support to come together, and family and friends and neighbors to gather together around those who have lost someone that they love and offer them their love and their support so that they have a sense that they don't go through this alone. It's really too bad that funerals are becoming somewhat scarce in America, because it means that people have to deal with their grief all on their own without the help that the funeral service can give them. Death is an inherently spiritual experience. I mean by that while a person may not be very spiritual their whole life long and may simply live their life from a very natural and material perspective, just dealing with sights and sounds and facts as they come up, and not admitting the existence of God or the supernatural, when a person dies, it becomes natural then for them to ask the question, is this all there is? What is the world going to be like when I'm no longer in it? What am I going to be like after I've died? Is there anything after death? These are spiritual concerns. These are ultimate questions. Questions like, where did I come from and where am I going? And what's the purpose of my life? And what's the meaning of it all? And is there anything else beyond all of this? Are fundamentally spiritual questions. And spirituality, as you probably know, usually gets translated into religion in different forms. We are all inherently spiritual, and our spirituality gets expressed in terms of religion. And religion certainly has something to say about death, and it certainly has something to say about healthcare. In fact, one could say that it is out of a sense of compassion and love, which doesn't really make any sense unless you have some sense of God and spiritual realities. We take care of one another, and we go even to the gate, walking them to the gate of death. Death is a spiritual and religious enterprise, and the help that we have to offer people who are dying mostly comes out of spirituality and religion. We try to give people a sense of hope. We try to give them a sense that they are not abandoned, that they are not alone, that even if the worst should happen and they should die, there is still meaning and purpose in that, that they don't need to be afraid, that there is something that comes after, that there is a better world, a better place, a better life. And even if they don't believe in that we can still help them to discover a sense of meaning and a sense of purpose and a sense of value in their life, even if that is something that they discover apart from God. So the spiritual dimensions of death and dying are profound, and they reach in all directions. They reach forward to the afterlife. They reach backward to the question of where did I come from and how do I connect with all the rest of humanity that has come before me, that has lived and died. It reaches outward to embrace other people as brothers and sisters, as fellow travelers and human beings. It reaches upward to God. It is a profoundly religious experience, both to die and to watch someone else die. That can be a good or bad religious experience, but it is a profoundly religious experience. Christian theology has a great deal to say about death and dying. In Genesis, it says that death was never intended to be part of the scene, that death was never supposed to be part of the human experience. Christian theology says that death came in as a consequence of sin, and sin came in as a consequence of human beings using their God-given gift of freedom to make bad choices. So to say that death was not originally intended to be part of the human experience seems to be warranted in the Scripture and also in human experience, since we really don't quite know how to handle it or what to make of it or how to understand it. Christian theology says that Jesus Christ died a death that can take the place of death for all of us if we are individually willing for that to be true. In other words, that while we may all die as a result of being human, we don't all have to die the ultimate death, which is the price of sin, because Jesus died it for us. The Bible actually talks about two deaths, a first death and a second death. The first death is the death that we all die as a result of being human. The second death is the death of eternal separation from God forever and ever and ever, a death that Jesus died in our place, according to Christian theology, according to what the Bible has to say. So if it's true that the first death is only a temporary death, a kind of sleep from which we wake to experience eternal life, then that has profound consequences for those who are experiencing dying. In other words, it's possible for a dying person to say, this is just going to sleep. This is not so bad. I can go to sleep. In fact, I'm kind of tired. I will look forward to the day when I will wake up and I will be fully healthy and fully alive, and I will be with God in a place where there will never again be pain or sickness or suffering or death. That has a profound effect on how a person experiences the dying process. Compare it, for example, to a person who says death is the end. You close your eyes, that's it. You never open them again. You're gone. You never ever will see your loved ones again. This is the end of everything. That's a profoundly different dying experience than the one I described a few minutes ago. So whether it's true or not, you will have to decide for yourself. Personally, I choose to believe that Jesus knew what he was talking about, and that he's an accurate source of truth on this subject because he is, in fact, who he said he was. Other people come to different conclusions and say, nah, I don't think so, and that's certainly your privilege. God gave you the right. In fact, one could say Jesus died so that you would have the right to come to your own conclusions and express your own choice on this subject. But just know that what the Bible has to say, what Christianity has to say about death, is a profoundly life-changing experience for those who believe it. Other religions, of course, also have their own theologies of death, that when you die, you go to this place, or when you die, you are absorbed into the eternal nothingness of the cosmos, or whatever it might be and however it might be explained. A good world religions class can help you to understand the different theologies of death present in different religions. But the fact that human beings have theologized about death, that is to say, the fact that human beings have attempted to understand death from a spiritual, religious, philosophical perspective is not at all surprising, because death is the great experience of human life and the great mystery, the great imponderable, the great last obstacle to be overcome, and therefore it tends to occupy and preoccupy human beings' thinking about life and purpose and meaning. I hope that all the conversations about death have given you a sense of hope, that in spite of the fact that death is a bad thing, that there are things that we can do that help people who are dealing with death in a very real way, that we can help people to walk through this process in a way that is healing, even if they ultimately do die. In other words, that relationships can be healed, that understandings can be healed, that grief can be healed, that confusion can be healed, that hatreds can be changed into loves, that the experience of dying can be a good experience for people, in fact, one of the best experiences of their lives. Not only that, but there's also hope, because according to Christian theology, death is not the end. It's simply a well-deserved rest at the end of a long and useful life, and there is hope on the other side. In addition to that, we do have a lot of great things that we can do for patients, including taking away their pain. You remember that Dr. Bioch says that in this day and age there is no excuse for people dying in pain, for people suffering their way to a horrible death. We do have things that we can do, and it's a great thing to be able to offer patients and their families that kind of help from modern medical science, that they can know that their death or the death of their loved one is not going to be a torture. It's important to always hold out hope to people. People don't live long without hope. It's a horrible experience to be utterly hopeless. By your ministry of presence, by your compassion, by your honesty, by your humility, by your craft and your knowledge, you are uniquely positioned to offer dying people and the people who love them hope. and I hope that you will.